Good morning, everyone. This is Dr. Vliet, and welcome to America's Fabric. I'm an independent physician with a practice in Tucson and Dallas, and you can follow me on Twitter at Health and Sense for the latest updates in health and your well-being, as well as all of the current events. Welcome to our show today. We're going to be talking about the concerns about Ebola and other hemorrhagic fevers. And I have with me a very special guest. I'm very pleased that he agreed to do this interview with me today. Dr. Stephen Hatfill is an American physician and scientist. He's a virologist and a bioweapons expert with a background in military special operations and training in emergency and tropical medicine and pathology. After serving as an overwinter physician in Antarctica, he obtained separate master's degrees in microbial genetics, radiation biochemistry, hematological pathology, and has 16 published scientific research papers. He was awarded the U.S. Army Parachute Wings in 1975 and the Rhodesian Army National Defense Medal in 1979. His postdoctoral fellowships include Oxford University, the National Institutes of Health, and the National Research Council, where he studied the Ebola virus at the U.S. Army Institute for Infectious Diseases at Fort Detrick, Maryland. In 2000, he was certified by the UN as an Iraq weapons inspector. He is an adjunct assistant professor at a leading university and operates a remote jungle training facility to test new equipment and to train other scientists to conduct research in high biodiversity areas. For the last 7 years, Dr. Hatfill has trained U.S. Army, Navy, and Marine Special Operations units in tactical combat casualty care. He is speaking to us today as a board member of the American organization Doctors for Disaster Preparedness. Dr. Hatfill, welcome to America's Fabric today, and I just commend you on your incredible diversity of work and dedication to these disease issues and to the research and training of others. Thank you for joining us.
Well, thank you very much. I'm happy to be here.
Well, we are facing a number of emerging diseases worldwide that have people getting concerned because there's such a mixture of information out there. And I wanted to have you on the show to talk today, have us talk as two physicians who are concerned about people getting reliable, peer-reviewed, science-based information to help put the situation in perspective, understand the risk accordingly, and understand what we need to be doing to prepare, protect ourselves, and some of the issues that we face. I've been concerned that the national media has been exaggerating both the fear end of the continuum as well as the saying, oh, it's not that big a deal, we'll get it controlled, and making people feel falsely reassured when yet we see medical professionals wearing hazmat suits, and the disconnect doesn't make sense to most people. So let's see if we can bring some common sense, some reason, and science-based information to our audience today.
That sounds like a very, very good idea.
Okay. So let's start with a little background on the emerging diseases as a concept and what you are aware of that our country has been doing to improve surveillance and detection.
Well, this has been a problem dating back to the 90s. Dr. Peters, Clarence Peters, very experienced virologist, had an appointment at the CDC Special Pathogens Unit. And he was quite instrumental in bringing out this concept of emerging disease and the fact that we needed to prepare our surveillance method for this. Now, by emerging disease, I mean really, there's roughly only about 1,407 organisms that are capable of causing human infection. About 58% of these, 59% of these are considered to be animal diseases. And the problem has been that about 177 of these pathogens are either newly emerging or re-emerging diseases. In the last sort of 30 years, we've had 41 previously new unrecognized human infections jumping into the human population.
From an animal one, correct?
Mainly, about 58% of these are animal diseases.
Okay.
So the CDC decided very laboriously to upgrade the surveillance capabilities, and over the last decade, we've spent as a nation, about $120 billion improving surveillance for unusual disease outbreaks. Now, as with any government program, a lot of this money got wasted, but a lot of effective things were done and upgraded, and even as far as tested with exercises. So, outside of the Canadians and us, we are very unique in having the ability to pick up some of this stuff very, very quickly before it has a chance to spread.
Well, and that's encouraging, I think, for people to understand. Tell us a little bit more about the hemorrhagic fevers, of which Ebola is one of several, and I think it would be helpful for our audience for you to name some of the other ones in that group and then explain what hemorrhagic fevers are and what they do and why the death rate is so high.
The hemorrhagic fevers, when we use that term, we're actually including 4 different viral families with multiple names of viruses in each family. They range from the Machupo virus and the Lassa fever virus to Congo Crimean hemorrhagic fever to the Four Corners agent to the well-known publicized Marburg and Ebola viruses, all the way down to infections we've known for many, many years, like yellow fever and dengue and Rift Valley fever. They all share a commonality in having roughly a 7 to 14 day incubation period, depending on the amount of virus an individual's infected with. Sort of an acute flu-like illness during this time with a fever and muscle pains, sometimes gastrointestinal disturbances. And then the virus becomes more systemic.
And you mean by systemic that it spreads throughout the whole body?
Yes. And some of these attack the tiny little blood vessels in the body. It sets up a generalized inflammation in the blood vessel system. And you can start seeing various rashes and difficulties in bleeding, coagulation difficulties.
And to clarify for our layman's audience here, coagulation means blood clotting. Yeah. So the blood doesn't clot properly.
Correct. And Ebola and Marburg are in a family called the filoviruses. And those and Lassa fever and Machupo and Congo Crimean hemorrhagic fever have this very pronounced bleeding tendency in the victims that develops. And then, depending on a number of factors, including the individual's own immune system and their general health, nothing ever killed everybody, and there are survivors of all these. But typically, with Ebola and Marburg, 40 to 90% of the patients tend to develop a disease progression very similar to septic shock that I think everyone's heard of, and rapid progression into shock and death over a week or so.
And a lot of that may come from the blood loss with the bleeding and the clotting disruptions, correct?
Well, this is part of it, and anyone can Google this. It sets up a condition called systemic inflammatory response syndrome, or you can just Google SIRS. And it's this generalized inflammation of the blood vessels that leads to what we call multiple organ dysfunction. The heart, the brain, the liver, the kidneys, the lungs become inflamed, the blood vessels become inflamed. And this multiple organ dysfunction progresses on into multiple organ failure, just like in septic shock. And our mortality, even in this country, from septic shock really hasn't changed a lot since the 1980s.
And what is that mortality, roughly?
It's variable, but it's high.
And that, you said, hasn't changed significantly, even with our sophisticated treatments?
Not noticeably. The mortality and morbidity of this has been fairly unchanged since multiple organ dysfunction and multiple organ failure were recognized back in the 1980s.
So the disease, the hemorrhagic fevers, particularly Marburg and Ebola, carry very high death rates. Let's talk a little bit about the current outbreak in West Africa. You've worked in these areas. Tell us a little bit about what it's like.
Well, it's certainly nothing like in the United States and the healthcare system there. A number of years ago, I spent some time in the Congo, and really the closest hospital, there was one hospital that serviced roughly a 600-mile area. You're trying to bring 21st century medicine to these areas, and very often it's about the level of 19th century medicine. Your patients have no understanding of the germ theory of disease. There's a lot of animism there, belief in spirits and this type of thing, which is how they explain things in their own daily lives. It can be very, very chaotic situations, and this is just running normal clinics. When you're dealing with a large number of really terminally ill patients, it becomes, fairly out of control fairly quickly. You're also limited by the number of or amount of personal protective equipment. Many places, these rural hospitals, they use rubber gloves and they reuse them over and over again after autoclaving. So conditions are really fairly primitive. To get IV drips in and medications, I think in the Congo, it's still about a 2-week drive to get from Lubumbashi up to the Kolwezi area, which is about 600 miles. So if you don't have aerial support and this type of thing, or bring enough equipment with you, it becomes very problematic.
Well, and we've certainly seen that the World Health Organization has mobilized extensive resources for the West African outbreak. What we understand about the transmission of Ebola and some of these other hemorrhagic fever viruses, there's a lot of mixed information in the press today. There are people saying that some studies show that it can be aerosolized and airborne transmission. Others are saying categorically it cannot be. And I think the reality lies somewhere in between, and would like for you to comment on that, as well as what do we normally mean by aerosol and airborne transmission in the consumer's mindset? How do they understand it? What do we mean medically? And could you address some of the confusion that is so prevalent in the media today?
When we refer to aerosol transmission, most people think, well, like the flu virus or influenza. Somebody sneezes and I get the particles on my fingers or I inhale it, and the disease is transmitted through the air. In reality, for an agent to be aerosol transmitted, it's a fairly complicated thing. It depends on the size of droplets that the person coughs or sneezes out. It depends on the amount of virus that's in those secretions. It also, our upper airways have a very active defense mechanism against infection, and our lower airways as well. There's some very integrated defenses ranging from mucus and the ability of little hairs in our airway to sweep things out, to spiraling the air if we breathe through our nose, and taking particulate matter and putting it against the mucous membrane where we swallow it or spit it out. So it's a very complex interplay between droplet size, our airway defenses, the infectivity of the viral agent, in other words, how many viral particles is necessary to initiate an infection. What we do is we look at the case studies of people that have contracted different diseases. And we see if close proximity is a factor, and if the statistics indicate that there is airborne transmission. And the traditional studies of Ebola in small families and this type of thing suggest a more direct contact rather than droplet spread. Another factor that's included is when these organisms are put out into the aerosol, how fast do they decay? Viruses like to be in the body. They don't like to be in an aerosol. And different viruses decay at different rates. One of the reasons that smallpox was so dangerous was because it had a very low percentage decay rate per minute, which meant it could stay in the atmosphere for quite a long time before the droplets settled out. Ebola doesn't tend to show that aerosol stability. There are studies, and these are laboratory studies, saying that it can happen. To use the word never in medicine is always incorrect.
Well, I would agree with you on that. In fact, I thought I was impressed with the quality of the information in the Canadian Public Health Advisory, and their statement, based on 2012 studies with primate species, was infection through, and I'm quoting here, infection through small particle aerosols has been demonstrated in primates, and airborne spread among humans is strongly suspected, although it has not yet been conclusively demonstrated. And I thought that was a reasonable statement. I'd like your comment on it.
Oh, the Canadians are very, very smart in this area. They were instrumental in getting the GFAS surveillance system up, which is a worldwide thing like ProMed, but a little more proactive for disease surveillance. These studies, again, demonstrating the ability of aerosol transmission in a non-human primate model is pretty definitive data. Again, we're not monkeys, but it does put the flag up. In addition, we have different viral strains. This is why we have sometimes a varying mortality. The Ebola reston strain is not pathogenic for humans, but it destroys monkeys. It's horrible. People have been exposed to this, and they develop antibodies, so we know the virus entered their bodies. But they have no symptoms whatsoever. This is how sometimes viruses tend to become a little better at transmitting.
They mutate or change over time, correct?
Yes. Oh, yeah. Ebola's changing. These are RNA viruses, and they tend to make mistakes when they replicate. They change with time.
So one of the things I wanted to just get you to comment on, and the things that we don't get to in this show today, we will address in our second show in the series on this that I'm going to be doing with you. The other thing is, I think the disconnect in the mind of most of the people that I have talked to about it and the public who are laymen is that they see the scientists and medical workers in these protective suits, these very complex protective hazmat suits. And so the idea that there's no other transmission except bodily fluids just doesn't make sense to a lot of people. And I'd like you to talk a little bit about the protections that the medical workers need to use. We know we've had over 100 medical workers in West Africa already becoming ill, and some have died, even though they use protection. So let's talk about that and what the issues are with droplets and getting it on the skin and the eyes, because I know the virus attacks the skin as well. So could you talk about that?
This was a problem that was addressed over a decade ago. The Nunn-Lugar-Domenici Amendment required that the 120 largest cities in the United States, their healthcare personnel, be given some training, and one of the things was hemorrhagic fevers. the CDC, USAMRIID, a number of very, very smart people made a consensus that these patients could be nursed by using what's called universal barrier precautions, shielding the eyes from droplets, preferably wearing a high-efficiency particulate air filter mask. These are the ones that make you look like a duck, Donald Duck. They have high-efficiency filters built into the material, although they're put on like surgeon's gowns. Having, just like we would nurse a patient with hepatitis B, wearing double sets of examination gloves, wearing a surgical gown, having a lock-in, lock-out sort of basic decontamination procedure when you enter and leave these patient treatment areas. This isn't always practical in Africa, and we've had Ebola outbreaks before that were successfully managed with nothing more than wearing masks and eye protection, gloves, and a little bleach shuffle pit that the individuals walked in and out of and changed their gowns after they dealt with patients. Epidemics have been happening with such regularity over the last 10 years that I think they may have lost a little bit of their interest, and perhaps the response to this was a little bit slow. Anyway, regardless, perhaps the virus is a little bit better at transmitting. We don't know yet, but or I haven't seen the work yet. So we know how to control these diseases. We've known for 100 years. So the reason for wearing the space suits or the positive pressure Raquel respirators and the Tyvek and this and that, if you have this material and you're working in a rural area, by all means you want to use it. Ideally, you want these patients in a negative pressure room. So if there's any leak of the airflow, air is pulled into that room and passed through filters rather than blowing out of the room. So if you have these are just ideal. And if you have the capabilities, it's silly not to use it. But basic barrier nursing is effective.
Good. That's helpful to know, I think, for many of our listeners. And I'd like to have us talk further about this in an upcoming show where we'll talk more about the evaluation and treatment and the new medication that has just come to light, ZMapp. We'll talk more about that. Is there anything you'd like to leave our listeners with today as we wrap up?
Well, this whole concept of emerging infectious disease. Our species numbers has doubled over the last 27 years. In the process, we're fragmenting native animal habitats. Wild animal food sources become less diverse. We've have this process of intensive domestic animal breeding for food, which makes some of our animal population very susceptible to wild viruses coming in from outside. We do intensive orchard and crop culture, and we're sort of driving and disrupting the ecosystem. These are paramount things for setting up for an outbreak of emerging infectious disease. Hence, it requires a very strong continuing public health effort and a strong continuing surveillance effort.
And I would add to that, it requires people to take responsibility for their health, to do things to stay healthy, and to be attentive to basic hygiene, hand washing, sanitizers, not going out if you're sick, and being aware of things you can do to avoid immune system damagers like too much cigarettes and alcohol and the wrong types of food. So basic preventive medicine is the part of all of us to do our part as well. Oh, thank you for joining us today, Dr. Hatfill. I'm very, very pleased that we could do this. And stay tuned, everyone. We will have the second in this series on the emerging diseases, hemorrhagic fevers, and Ebola coming up next week on America's Fabric. This is Dr. Vliet signing off for today. Follow me on Twitter at Health and Sense, and be educated, aware, and stay healthy.